Good evening, everyone. Welcome to our webinar, Is Medicare Advantage Driving Your Provider to Despair and Why You Should Care? You're going to hear from our speakers, Dr. Carol Parrish and Dr. Diljeet Singh, about how the healthcare industry is causing significant emotional and ethical harm on healthcare professionals and significant consequences for their patients. I'm Karen Richter, co-president of PSARA, the Puget Sound Advocates for Retirement Action. For those of you that may be new to PSARA, we're a multi-generational statewide organization of about 1,500 members who advocate for seniors, their children, and families. We support efforts to allow all people to live their lives with economic security, dignity, and respect, and in a clean environment. We fight for the protection and expansion of Social Security and Medicare. We also have very active committees working on climate justice, social and economic justice, racial justice, including reparations for African Americans. We host events and conduct webinars and have a monthly newsletter entitled The Retiree Advocate. Our website, PSARA.org, is filled with information, articles, events, and links to all the other webinars that we've hosted. I encourage you to take a look at and learn as much about us as you'd like. We would love you to join us and support our work. This webinar will run about an hour, maybe an hour, 10 minutes, with a question and answer period at the end. Please put your questions in the Q&A and not the chat, as we're not monitoring the chat. Now I'd like to introduce our moderator for tonight's program, Jaisri Lingappa. She is a University of Washington Professor Emeritus of Global Health. Jaisri obtained her PhD from Harvard University and her MD from the University of Massachusetts. She trained in internal medicine and infectious disease at the University of California in San Francisco, where she cared for people with AIDS at the General Hospital there, starting in the late 1980s when there were no drugs for treating AIDS. She joined the faculty at the University of Washington in Seattle in 1999 and retired after 23 years of a National Institute of Health funded research career focused on understanding how viruses like HIV hijack host proteins. While at the University of Washington, she also taught graduate students and undergrad and was the recipient of 3 teaching awards. She lives on the Olympic Peninsula in Washington State. We are very fortunate to have her as a very active PSARA member. So Jaisri, after you.
Thank you, Karen, for that introduction. It's my great pleasure today to introduce our 2 guests, Dr. Carol Parrish and Dr. Diljeet Singh. Dr. Parrish earned her medical degree from West Virginia University School of Medicine and is a past president of Physicians for a National Health Program, also known as PNHP. Now retired, Dr. Parrish worked for more than 25 years as a psychiatrist in private practice. She has also worked in community mental health settings, academia, and with incarcerated persons. She lives in Sewanee, Tennessee, where she focuses on mentoring medical students and early career physicians. Moral injury in healthcare is one of her primary interests. Dr. Singh is a women's health advocate and an integrative gynecologic oncologist, currently in clinical practice. She received her medical degree from Northwestern University and master's degree from the Harvard School of Public Health, and trained in obstetrics and gynecology at the Johns Hopkins Hospital and MD Anderson Cancer Center. She currently serves as vice president for Physicians for a National Health Program and will be the next president of PNHP. Some of you may recognize her from a recent, very impressive PNHP Harms Report webinar, and we'll actually be talking about that PNH Harms Report in a little bit. Before we get started, I want to say a little bit about the topic of tonight's webinar and put it into context. Recent webinars by PSARA have focused on the direct harms to patients caused by the policies of Medicare Advantage, which is the private insurance company's alternative to original Medicare. These harmful Medicare Advantage policies include delays and denials of care, which allow Medicare Advantage insurers to reap huge profits. And I should point out that those policies are not used by original Medicare. which is also called traditional Medicare. Today's webinar will focus on another less obvious but very concerning way that for-profit corporate insurers harm patients, namely by forcing healthcare professionals into crises of conscience when they are required to carry out harmful corporate policies that delay and deny necessary care. So these crises of conscience that healthcare professionals experience are referred to as moral injury. So today we'll start with about a 30-minute discussion of what moral injury is in more detail than my thumbnail sketched, what causes moral injury, how it affects healthcare professionals, and why it is of particular concern for seniors, over 50% of whom are now covered by Medicare Advantage rather than original Medicare. After that, we'll take questions from the audience for about 20 minutes, and then PSARA co-president Karen Richter will make closing remarks. And I want to remind the audience, put your questions into the Q&A. There will be some links in the chat that you may want to refer to, but questions should go into the Q&A. So thank you again, Carol and Diljeet, for being here today. I want to start by asking each of you to define what the term moral injury means as it relates to healthcare professionals and how moral injury differs from burnout. So Carol, why don't we start with you and then Diljeet?
Thank you, Jaisri. I'm glad to be with everyone this evening. And I think I'd like to start by saying that Diljeet and I gave a workshop on moral injury at the last PNHP annual meeting. And we really thought that, you know, we were competing with some other really good topics. And we weren't expecting more than about 15 people in our workshop. And it turned out that it was standing room only. And the interest was from medical students all the way through early career, mid-career, late career, and retired physicians. And it just made it very clear to me that this is a topic that is really relevant to the physician population. And so I'm glad that PSARA is also making the connection that, you know, when doctors aren't feeling great about what they're doing, the real harm is done to patients. You know, we're supposed to be able to take good care of our patients and have the energy and the joie de vivre to do that. So that's why this topic became important to me. So I'll just begin by saying that the concept of moral injury actually originated in the military when they found returning veterans coming back with symptoms that they originally formulated as PTSD. And what they found is that these returning vets were not getting better with standard PTSD treatment. And so they started studying it further. And what they found is that anxiety and avoidance, which is caused by fear, which are sort of hallmarks of PTSD, were not what these vets were endorsing. What they were talking about is feelings of shame and guilt about conduct that they perceived as immoral, either conduct that they did or they were prevented from doing. And so from that research, a new term, moral injury, was introduced. And it's defined in the military as perpetrating, bearing witness to, or failing to prevent acts that transgress deeply held moral beliefs and expectations. So that's sort of the military's definition. In healthcare, what we have found is that doctors are daily expected to transgress their oath, the oath to put the needs of patients before all other considerations. And so when we find ourselves in these situations where we're expected to transgress this oath because of the business of medicine getting in the way, that results in what is called moral injury. And let's not forget that healthcare has become a $5 trillion business, and the profits of shareholders and investors takes precedence over the care of patients. We were talking before the opening that, you know, to insurance companies, their customer is their shareholders, not you guys, the patients, not the doctors, but the shareholders. So that's moral injury. And burnout, on the other hand, is what Wendy Dean, who is sort of she literally wrote the book on moral injury. She describes burnout as a demand resource mismatch. Demand resource mismatch. Whereas moral injury, she says, is an experience that is based in betrayal. And so I like to think of it for an analogy, if I can give this quickly. You can think of doctors as being like Lamborghinis, really well-designed machines, cars that are, you know, we're designed to perform well. But if we don't change the oil, if we don't put air in the tires, if we don't do routine maintenance, even a beautiful machine like a Lamborghini won't perform well. And that's sort of the equivalent of burnout. And the solution is to do proper maintenance on the machine. So that's where all the focus of the intervention is, to improve the machine, to make the machine better. Whereas in moral injury, you can think of it as taking this beautiful Lamborghini and day after day after day, expecting it to drive down a narrow, pothole laden road that has you know, abandoned vehicles and tire rubber and all those things that make it really hard to go down the road. And yet day after day, doctors are expected to find a way to get around all of these obstacles. And that's sort of the equivalent of moral injury. So what needs to happen is you need to make the road better and safer so that the machine can continue to perform well. And so it's the system or the road that needs to be improved, not the machine itself. I hope that helps. And Diljeet, you can take it from there.
Sure. But listen, I did want to say thank you. Thank you so much for having both Carol and I, and for helping us talk about the harms report and, you know, the taking advantage report, because I think it's so important and so meaningful. And, you know, for me, how do I think about moral injury and burnout? I think, you know, I like Carol's analogy, and I really do like how Wendy Dean talks about it in the many different venues that she does, both in podcasts and in books and in articles. If you search Wendy Dean, you'll find it. But I think the key piece and the key difference is, you know, I've been burnt out in my career, right? When I first went into practice, I was, you know, had an apartment in New York City, and I was working at Columbia, and I was trying to finish my PhD, and I thought that I could also, you know, get my OBGYN boards, then my gynecologist boards done. And I was kind of overwhelmed by first being a doctor and, and suddenly having like all the responsibility and teaching residents at the same time. And I didn't take a vacation for 2 years because I thought like that's how you did it. And I was burnt out. And, the ways we think about burnout, it's emotional exhaustion, it's depersonalization, it's decreased sense of personal accomplishment. And that is something that I could fix, right? I could not sign up for every committee that came my way. I could remember to eat breakfast. I could get back to spending time with my family on the weekends. And I could do a variety of things that would allow me to take joy in my profession and do it well. That's burnout. And that is solvable on an individual basis. Moral injury is every single day, I give people treatment that's not exactly what I think they should have, but it's what the system will let me do. And what I really think they need is to start their cancer treatment as soon as possible. But I'm just going to suck it up and accept that I can't get them to the OR for 4 weeks and I can't get them a PET scan for 3 weeks. And there's no endocrinologist here. So I'm just going to have to fudge it a little bit and get their Synthroid right, their thyroid medicine, even if I'm not an expert. And I'm going to give them what I was taught is substandard care. And I'm going to do this over and over. And I'm going to apologize to them for the system. And I'm going to feel helpless to fix the system in any way. And that's moral injury. And, was I suffering when I was in burnout? No, I was a little bit stupid, and not to minimize it in any way. It was certainly a difficult lesson to learn. And like many, physicians, I learned it very early in my career. This moral injury is a whole different ballgame because there's no learning it. And really, why am I the president-elect of PNHP? Because it is the only way I can cope with the moral injury of being a gynecologic oncologist in this system. And, the thing that's tricky for me is, and I'm afraid that we're still not using the right word, because when I hear moral injury, I'm like, okay, so the guys in the military, they had moral injury because they didn't feel comfortable killing people because, we're raised to not kill people. And so like in their professional role, they were doing something that just didn't feel right for them as human beings. And, when we talk about moral injury, like, I just feel like it should be like, fire engines show up and, like for us to be taking care of people and all the time feeling like we're doing the wrong thing, like, so we clearly don't have the right word because I still think that people don't quite understand it. And I honestly, I like the way you all introduced this session, because I think like that, those are some words and some language that maybe we would help, because I think if people really thought like, oh my God, does my doctor think she's doing the wrong thing? Wait.
Or at least not the best thing. The thing that we were trained is to provide the optimal care. And when I know what the optimal care is, and I don't provide it to my patient because I can't.
There was a period of pretty severe chemotherapy shortage for a drug called carboplatin, which is an older drug, extremely effective for a number of cancers, lung cancer, but also gynecologic cancers. And it's actually the #1 most effective chemo for gynecologic cancers. And we had a shortage in the summer of 2022. Am I right? No, the summer of 2023. And the reason we had a shortage was because nobody could make a lot of money off it. And so it had gotten pushed off to generics, and it was being made in countries that don't have the same kind of surveillance and monitoring of drug making, and so one of these companies was shut down. And next thing you know, we don't have enough carboplatin in America. And we start taking the drug and going from the middle of the dose range you're supposed to use to going to the bottom of the dose range. And we're supposed to give the drug every 3 weeks. Well, now we're going to do it every 4 weeks. And, you know, if part of the national guidelines that came out were, you know, if you're not using it for curative intent, if you're using it in someone where you're just prolonging their life or trying to improve the quality of their lives, two things that I think are as important as curative intent in my job as an oncologist. But, you know, the guideline said, then you shouldn't be using carboplatin, then you find an alternative drug. Now, I don't even know what to say, right? Like I want to vomit. And at the time I did, and it just made me insane. And people would clear up, ask me, Dr. Singh, you think it's okay to decrease the dose? You think it's okay to put me on this alternative medicine? And all I could say was, we just don't have the drug. And I actually worked for a company that was a vertically integrated pharmaceutical to provider organization that actually had more drug than a lot of clinics in the country. And I don't even, you know, I know what some of the clinicians did in those settings, but I mean, I think that's something that happens because, you know, making carboplatin isn't about curing ovarian cancer or curing lung cancer. It's about making money, making the drugs we do, et cetera. And so that's the problem that's built into our system now of why it's possible that doctors should even feel moral injury.
Right.
Yeah.
Anyway, our priorities are not aligned. The priorities of physicians are to put our patients' needs before all other considerations, and the medical industrial complexes goal is to maximize their profits. So our priorities are completely misaligned.
So yeah, those are all super helpful examples and analogies. Are there other examples from sort of daily practice that you want to tell us about? Like how often is this happening, and how what about situations where it isn't an issue of a drug being unavailable?
Well, I think that the things that we think about, you know, I was blessed during a long period of my career when I was focused in academia to work in urban centers. And even when I was with Kaiser Permanente, I worked in urban centers. And more recently, I've been working in more rural settings, Roanoke, Virginia, and now more recently in Green Bay, Wisconsin. And I think the availability, and this struck me more in Roanoke and even in like the Norfolk, Chesapeake, Virginia area, you know, not having a specialist, right? Not having a specialist to help you make decisions about how to manage thyroid disease on immune therapy. And you might think like, wait, what? We know these immune therapy drugs that are incredibly effective, and people can be on them for a long time. They don't have the kind of side effects that we see with chemotherapy. They cause other weird side effects, and one of them is that they cause changes in people's thyroids, but they're kind of odd and unpredictable. And as somebody who didn't spend 25 years practicing as an endocrinologist and didn't spend 7 years of training as I did to be a GYN oncologist, I rely on people who do that every day, and they know that. And just the idea that you can't get a patient in to see somebody. So instead, you either suboptimally treat them, or you just kind of like read about it and kind of fizzle your way along. You know that people deserve the best. You know they deserve expertise. To me, the other big thing, and again, I'm an oncologist, I use oncology parallels. Early in my practice, it was our belief that, you know, number one, if somebody came to you with ovarian cancer, our goal used to be, one, to see them in our office within 72 hours. And ideally, if there were no other concerns, get them to an operating room if that's what they needed within 48 to 72 hours. And in general, we were able to accomplish that. And that is just not a part of American medicine anymore, right? There is no such thing as that. And there's plenty of time now where I know we can't get somebody to the OR that quickly because we can't get their scans, we can't get them their pulmonary tests, we can't get the operating room time, we don't have the access to the anesthesiologist the way we need them, that sometimes we ultimately don't even start out with surgery. We decide, okay, if we don't want to wait, 6 weeks, maybe we start with chemo, knowing that maybe we can get them to chemo a little faster. Again, though, getting a port, getting those scans, getting any tests back we need. We used to start chemo within 48 to 72 hours of an operation because that's when there were the fewest ovarian cancer cells there. Now we never do that for several reasons.
And the reason is because of the need to get.
Well, there's several, right? One of the reasons, so one of them is the pre-authorizations. But even beyond that, even, the other reason we often aren't able to start is because of how the system was built. We used to be able to give people chemo during a hospitalization for an operation, but then for whatever reason, you couldn't get reimbursed. Any insurance company wouldn't pay for drugs. They would say that's a surgery, a hospitalization. We're not going to pay for chemo. So instead, you let them get then you have to send somebody home. Then you bring them back again, and that was the beginning of moral injury, right? Because even like people who I knew who were like experts, the top of their field, the chairman of MD Anderson's gynecologic oncology program, felt helpless to try to change that system, even if he knew the other way was to do it right. And yes, all of these things, not being able to get people to the specialists they need, not being able to get them approval. And, some of the data from the harms report that was really, even I hadn't realized, was how narrow networks really are. When people are trying to see a specialist, how many doctors in their town they are not eligible to see because they have a narrow network. Similarly, like the idea that the vast majority of denials that are appealed are ultimately overturned, but people don't appeal denials, both on the medical side and on the patient side, because you believe it to be legitimate, right? That's different than the pre-authorization process, which that's just another stupid, if I'm doing a scan that is like part of the standard staging of a common diagnosis, why I need some system to tell me that I can get the scan, it doesn't make any sense.
So let's back up just a little bit, because you're getting into some of the concepts that relate to Medicare Advantage authorization.
They're true of all private insurance. They're true of at all anyone who has. The difference is Medicare didn't used to have this, right? For the first half of my career, I used to be so relieved when I saw a patient was 66 years old, because they'd be like, awesome, they have Medicare. I don't even have to worry about all that stuff. I'm just going to get their cancer treated. And, now that's like a back in the good old days story.
Yeah. And so give us a little bit more insight into why Medicare Advantage, which is essentially the Medicare option that inserts corporate insurers as the middlemen between Medicare and providers, why that has become the poster child for moral injury. So maybe you can fold in, Carol, bring in the report, the harms report on to help us understand why Medicare Advantage really has changed the landscape for Medicare patients, like Diljeet just mentioned.
Well, I'm going to let Diljeet go into the harms report itself. I don't actually think that Medicare Advantage is the poster child for sort of the cause of moral injury. As Diljeet just said, it's it is the financialization of our healthcare system across the board. And Medicare Advantage is just one really good example of that, an outrageous example of that. But doctors deal with these things if they're treating patients under 65 who are in high deductible health plans or employer-sponsored plans or ACA marketplace plans that are have so much cost sharing that patients that can't even afford to use their insurance. And so I really think that I wouldn't just single out, I think moral injury, I think if you're talking about moral injury, that happens across all aspects of our healthcare system. It's just that Medicare Advantage is an area that we've done a lot of work on, and it's a great example of something that can cause, can worsen moral injury for physicians.
And it sounds like from the harms report, it sounds like you can do the comparison of what original Medicare or traditional Medicare offers versus Medicare Advantage. And maybe Diljeet, do you want to comment more on what the harms report found in terms of the quality of care?
So you're right, Jaisri. We didn't quite say it. So what does it mean? So traditional Medicare was essentially insurance plan that was anybody over 65, you got your card, and there were groups, you know, thinking the word, I'm having word finding difficulties at the end of my day. You know, there were an organized approach to saying, okay, within gynecologic oncology, for example, there was an advisory board that advised Medicare about what studies had come out, what would be approved, what tests should be a part of it. A lot of the really wonderful guidelines that we have within cancer came out of the interplay between physicians and Medicare about the National Comprehensive Cancer Network, right? If you see an oncologist, they might give you a list of what the NCCN recommends or show you a algorithm for what treatment they're going to give you. So at some point along the way, and I'm not going to spend the time because it just gets me bitter and angry, we basically, our legislature decided that we needed more effective care and cost-effective care. And who could help us with more cost-effective care? Oh, businesses, because they're so great at doing things cost-effectively. And so essentially we started a project, and then the project became Medicare Advantage, and we started using them, in quote, as a middleman. And the thought process was, well, in traditional Medicare, we have this thing where as an oncologist, I would get paid for a visit that I saw or a surgery that I did, not for a patient with ovarian cancer, right? It would be the individual things that we did that is how the clinic or the hospital would get paid. And Medicare Advantage gets paid per person. And so the theory was, well, this means we're going to just do care more efficiently. What I have to say, our legislators were just like out to lunch or dumb or what? Well, these companies are in it to make money, And I have a PhD in cost analysis. I understand the whole issue of like, what do we do with resources? And the language that we've always used within the cost analysis and public policy world is we have limited resources to do what we need to do. And so let's decide how to use those limited resources. Well, I promise you, United Healthcare does not think we have limited resources. They think this is just a little pot of gold at the end of the rainbow, and they can make as much money as they want. And suddenly we are putting billions and billions of dollars more into Medicare, right? And so I do think the one lesson I've learned from these companies is that maybe we shouldn't be so constrained about you know, what we're doing with our resources, maybe we should do it the good old-fashioned way of like, what do people actually need to have the best, longest quality lives they can? And then let's make decisions around that and figure out how much money we have to spend on them. I saw on the question Q&A that there's some, you know, questions around this triaging process and even questions about preventive health, et cetera. I mean, I'm going to argue, for example, why do we not focus on preventive health in American health, you know, medicine? Why is it that now, like, you go to wellness clinics to get like basic instructions on nutrition? Why do a lot of doctors say like, oh, eat a healthy diet and I can't give you any more advice? Because at somewhere along the line, we decided that the way that we were going to pay physicians and pay hospitals and pay clinics was based on disease diagnoses. Now, that doesn't make any sense because we don't want people to get disease diagnoses, but somehow that's where we got. And so we set up a system where, how do you reimburse? Well, you reimburse for a disease. You don't reimburse for prevention of a disease. As a matter of fact, that's a really low code now when you think about diagnosis codes. And we basically just gave up. Now, I think there were other things in Western medicine that we made some decisions where we had some, I would call, arrogance about indigenous medicine and what was considered women's work and, you know, learning to eat well. Well, that's something your mom teaches you, and us big doctors, we don't do that. And so there's other things involved in why we bagged on prevention. But I think the biggest piece was because we have a profit-driven healthcare system that organized itself in a way that pushed our whole system. But you were going to say, Carol, please.
Well, I think one of the things that we have seen as a result of this experiment of Medicare Advantage that was supposed to be more efficient and produce better outcomes for more people, which it has not done any of those things. In fact, by keeping their focus on maximizing their profits, here we are now in 2024, and they're not just perpetrating that on patients and making money on the backs of patients. They're doing it to whole health systems, to hospitals. And what we're seeing is that health systems like Scripps in San Diego recently decided we can't afford to accept and maintain a contract with Medicare Advantage plans because we can't do it for what they're paying us. Well, again, who really suffers as a result of that? It's patients, because patients either have to switch Medicare Advantage plans or switch all of their doctors in order to stay with a plan that isn't accepted by the doctors that they used to see. I mean, it's patients that are suffering from these decisions in the final analysis. And unfortunately, we're almost caught in the middle of it all. And while, as I said at the beginning, we want to do and we know what is the right thing to do, and we are just simply constrained at every turn by some other aspect of our healthcare system that's putting profits ahead of patients.
I want to return to something that Diljeet said earlier about how traditional Medicare, you used to feel incredibly relieved when you saw that a patient was on traditional Medicare because that meant you could deliver really high quality care. And yet, despite that, what we're seeing is that with every passing year, more and more seniors are enrolled in Medicare Advantage. And that trend is just, it's over 50% of seniors now on Medicare Advantage. And so one of the things PSARA has been working on is a concept to level the playing field, to a letter to President Biden asking that the playing field be leveled between, so that people could have a real choice between traditional Medicare and Medicare Advantage. Right now, people choose Medicare Advantage because upfront, it seems like the more cost-effective approach for patients. And yet what you're saying with this middleman corporate insurer there, it's not cost-effective when you think about their health in the long run. So I would love to hear what you both think about improving traditional Medicare and leveling the playing field so people have a real choice there.
Well, and I think, truthfully, I think this is, not to put everything on our legislators, but I think this is another place that they have done us harm, where essentially in order to be able to have Medicare, you have to be able to afford a Medigap program, because you have to be able to afford something that helps you with the huge out-of-pocket expenses that there are. And of course, there's no vision and dental and other coverage. And so essentially, I take care of some patients who they can't afford to go on traditional Medicare. And so I can't tell them that that's what they need to do. And there's a rock and a hard place kind of space there of, they're not getting the care that I think they should get on Medicare Advantage, but I can't in good conscience tell them to do this. And then there's places where they actually don't have the option, right? That once you have signed on, you can't get a Medigap plan. In order to qualify for a Medigap plan, you have to go through like a exam and all the other process, and you have to qualify, and you may not qualify. Why? Because you have cancer, and that's why you're seeing a GYN oncologist. And you might be too expensive to cover, so to speak. I think,
So I think that Medicare, when it was passed in 1965, I think they compromised on some things in order to get it passed. That's what they talk about. That's making the sausage. Well, now here we are in 2024, and the Medicare design is simply not good enough for modern day. And why is that surprising? Is there anything that we did in 1965 that we're doing the same way in 2024? I don't have a VCR anymore. I don't have.
We didn't have one in 1965.
I don't have a dial-up phone. Things change, and Medicare really needed to be brought into the 21st century, and we haven't done that. But we've allowed Medicare Advantage plans to kind of look like they're doing that, except they're appealing to the 80% of senior citizens who are mostly healthy and don't really need to. They look at their own use of their health insurance, and they say, why should I pay for a Medigap plan with traditional Medicare if I'm not using care? I'll just go with the free one. Because they're not thinking about the fact that at some point they're going to join that 20% of the population that actually is sick and needs to use care. And at that point, the chickens come home to roost, and you find out, oh my God, now that I'm actually needing treatment for cancer or for heart disease or for, lung disease, I find out that my Medicare Advantage plan, while it may give me, a free dental exam once a year, is actually going to bankrupt me now that I want really expensive care for a serious medical problem. And on top of that, the narrow network won't let me go to MD Anderson or Dana-Farber or the doctor of my choice.
I think that the whole idea that we can ever be good consumers of healthcare insurance, right? It's not really insurance. We want everybody to use their healthcare all the time. It's not just for a rainy day. There's an aspect of it that's for a rainy day, but we're really bad at predicting that, right? I know if I'm going to be working in Green Bay, I need my Toyota RAV4 that is 4-wheel drive because it's going to snow this winter, right? And I know that I have a dog who's going to track mud into the back seat, so I know what kind of seats to get in my car, and on and on and on. I know I'm going to drive across the country, so I'm going to need a hybrid, not an electric, because I'm going to need to stop. And I can be a relatively good consumer of buying a car. I do not know if I'm going to get a rare cervical cancer and need chemoradiation, and the best expert is, 150 miles away. And I don't know if I'm going to get a brain metastasis that needs a special kind of radiation that can be treated effectively and not give me whole brain radiation that's going to alter my long-term ability to think and cognition. But again, that's 400 miles away, and my insurance won't let me go out of network. I mean, I think that is the other problem, is that Carol was just describing. We don't know what we need, and
Or what we're going to need.
or what we're going to need. And I think the other part is that, like, because we've commodified it, like, we almost think of it the same way, like, oh, okay, well, I'm going to get a sunroof on my car. That's not the same as getting a silver sneakers plan, right? Silver sneakers is just not that expensive, and it really doesn't cost those guys anything. And the truth is, most people don't use all those little bonus things. Oh yeah, they cover dental, but there's not a dentist within 100 miles who takes that Medicare Advantage plan. So you don't actually get to use it anyway. And on and on and on, right? Like, even, the vision plans are the same way. They're so limited. There's one frame you can get. There's one optometrist you can see. And, people just, I mean, I hear great stories from people about, what they thought they were getting and what they actually got.
And so I think, to bring us back to, moral injury of physicians, we see this every single day. It is like death by 1,000 paper cuts. We see it in our patients. We see it in our own family members who make the mistake of getting a Medicare Advantage plan instead of traditional Medicare, or we understand why they made that choice, but then here they are bankrupting themselves because they've actually had the misfortune, or they made the bad decision to choose to get ovarian cancer, like anybody chooses to do that. So I just think back to, moral injury. It's what physicians experience every day, trying to take the best care of their patients that they know how, and every day, day in and day out, being prevented from doing that. And it just takes a toll. And the solution to that is not what Diljeet needed to do to treat burnout. There is no amount of time management and bubble baths and yoga that is going to fix that moral injury. What is going to fix that is acknowledging that the problem is with the system, not with the physician.
And this may be a good point to switch over to audience Q&A, and hopefully we'll give you some time in there to make additional comments too. Thanks for that spirited discussion. We will also be putting some of the links for the audience, some of the links we've been referring to, the PNHP harms report, and also the PSARA campaign to level the playing field between traditional Medicare and Medicare Advantage. We'll be putting links to those in the chat. So Robbie, help us out with some questions from the audience here.
Sure. Happy to do it. So I'm struck though by, and I hope you all understand, our experiences are when we go out and do forums, that people are choosing Medicare Advantage because it's what they can afford. And that there is the reality in Medicare right now that it is increasing racial inequities in the healthcare system because, as we know, the racial inequities in income, and still it's about 50%, even maybe a little over, of white people who are in traditional Medicare. The numbers are much, much higher for people of color, for African Americans, for all of the other communities of color. So just to ask a question that came out from one of our members of our audience, are there any ways physicians can effectively push back on the orders of insurance companies? Or will they be severe retribution if they do? Any group action? And that kind of fits into my question that I had. If physicians were to organize, even become unions, and be able to act collectively, to what extent might that increase your ability to impact the changes you're talking about? Physicians, the voice of physicians could be, and PNHP is demonstrating that, an effective voice for the kind of changes that are needed. Is there some kind of organizing that's going on among physicians to try and use collective action?
I think that there are a couple of different ways people are doing that. And you, Robbie, highlighted one of them is the consideration of becoming a union, joining physicians unionizing. That is certainly not the only way. There's another group of physicians, primarily emergency room and anesthesiology physicians in a group called Take Medicine Back, that are working on the corporate practice of medicine laws in states to try and make those enforced. The laws already exist, but they're not being enforced. PNHP is working on it through our work with specifically on Medicare Advantage and improving traditional Medicare, with always our eye on the ultimate prize, which is a national health program, possibly, hopefully modeled after an expanded and vastly improved traditional Medicare program. So I think there are many ways that physicians can take action. What I am concerned about is that at the individual level, many physicians really cannot speak out publicly and complain, because they may be, 70% of practicing physicians now are employed physicians. Mm-hmm. And many of them are employed by entities that are owned by private equity. Mm-hmm. And they would jeopardize their employment if they spoke out. My own orthopedic surgeon confided to me that he agrees with much of what I say, and he can't talk about it publicly because he would lose his job. And he confided to me that regularly the C-suite of his, entity that he works for tells him he needs to be doing more surgeries. And he says, if I did more surgeries, I would have to do surgeries that are not necessary. And I cannot ethically do that. And so he's stuck between a rock and a hard place. And if he talks about that publicly, he'll lose his job. And so what I said to him, and what I say to a lot of people who are stuck at this individual level, is you can join PNHP and work with us, and we can be the voice so that you don't have to be the individual voice. We can be the voice of physicians, because when it comes to the issue of moral injury, I don't think that the AMA is the voice of physicians. I think they're doing a little bit of work on burnout, but my concern is that they're conflating burnout and moral injury, and I think that does possibly more harm than good. But I really think that, and I think Diljeet said this at the very beginning, that she said, the reason I'm in PNHP and I'm going to be the next president, which I can tell you, Diljeet, it's a lot of work. And it is incredibly gratifying because you really do feel like you're making a difference and you're being able to be the voice of physicians, so that, again, so that individual physicians don't have to put their jobs on the line.
Diljeet, you want to answer that?
Well, I'm just going to speak to a slightly different part of the question that you asked, Robbie. So I think that, as we think about unions, and, Carol brought up the AMA, I belong to the Society for Gynecologic Oncologists, I've belonged to the American, College of OBGYN over time. There are a bunch of professional societies, but because we've created this profit-driven systems, what a lot of those societies have been driven to is basically like negotiating for and fighting for like some small piece of the pie. And it was, ENT docs against orthopedic surgeons against family practice docs for trying to figure out whose codes are going to get reimbursed what. And we've just spent a ton of, wasted time and energy of the collective action of physicians to do things that helped neither physicians nor patients. And again, it's because of how we built a system. It's because we built a system that's profit driven, and then we've got to regulate it down into a way and just kind of feed into this profit motive. And so, do I think, residents should unionize? Do I think there's a role for that? Absolutely. Do I believe that we can get to a place if we took the profit motive out and we went back to how I was talking about, how in Medicare, when we did a big trial on Taxol and carboplatin and decided that should be the standard of care, we could go to Medicare and go, all right, this is the research. You guys agree? Awesome. That's what we're going to do, right? Like, we could get there. I think it's going to take all of the above, though. Take back medicine, getting the lawyers in on this. The truth is, small businesses do not in any way benefit from a world in which they have to provide healthcare to their employees, right? How does a small business in America compete with Canada or, most of Europe or Japan to do their work or make their widget or whatever it is, if they're spending 30% of their, money on trying to support their employees. And even if we think about, as individuals, how many times do I take care of patients who say to me things like, I was really thinking about, branching out or starting my own business, but, I want to keep coming to see you and I'm afraid I might need chemo again. And so I don't want to change insurance. And to me, that's somebody literally not following their dream to keep their health care, right? Like this is just, these are so inconsistent with so many of the basic things that we consider, American values. Right. And so I think that we have to do all these things. Physicians for National Health Plan have to do our work. You guys have to keep doing all your good work. All of these organizations have to continue. I think, unions is another bandage that will fix this little problems, and we'll keep fixing, right? Like putting our fingers in the dike and fixing problems as they come. But ultimately, I think we need universal health care that's not profit driven. We take it out of the pharmaceutical business. We take it out of the device business. We take it out of hospice. We take it out of nursing homes. And we provide the services that people need to live the longest, best quality lives they can. And it'll automatically reprioritize things like prevention and, cancer prevention and vaccinations and all those other things.
I think it is going to require a movement of people and all the organizations working together to accomplish this. And I don't think just expecting that we're going to suddenly convince the members of Congress of the importance of this based on research and reason. I mean, that's never going to happen.
That's right. That's right. What you have to be able to do is you have to be able to deliver the votes.
Right.
And I just want to say, number one, that I really do appreciate the opportunity for PSARA to work with PNHP. I also want to say that we're keenly aware of the fact that now 80% of physicians are employees. And it's precisely that category that makes unionization possible. And I want to say every time workers organize, they risk their jobs. Every single time. Don't have any, you just have to understand that. Just doing that and deciding to take collective action puts your job in jeopardy. And you all now are moving into a situation where you're becoming employees. It's not like it was when you had a family physician who had the private practice and, was, just having that business. There still are a few of those, but that's not what's happening anymore. So I just want to put on the table the thought that you have a much stronger voice when you are collectively together and speak as one with one voice in a union, which is what we have found as workers, is that makes a big difference and ends up protecting your jobs as well. That being said, there's one of the things that, as you know, Puget Sound Advocates for Retirement Action has been pushing hard is that notion of leveling the playing field, because we believe that if people are given a genuine choice and are not having to make the kind of economic sacrifice that you have to make to be in traditional Medicare, that if we were able to level the playing field, people would make the rational choice. So I guess my question to you is, how, and I want to get this, if strong restrictions were, I think I know your answer to this, if strong restrictions were placed on private insurance companies, on prior authorization, on the delays and denials that you face, on having to delay care that your patient needs, and it just pains you right in your heart that you're not able to do it. If we were able, CMS just issued some rules about they cannot take as long doing prior authorization anymore. And one of our representatives in Washington, Representative Delbeni, wants to put that into law. But it's really not going to solve our problem, is it? What we really need is what we all understand is a healthcare system that's not built on making a profit. I think we're all, go ahead.
Yeah, I think that whatever we do legislatively to rein in the health insurance industry, they will always find a way to work around it so that they can continue to maintain their profits. Whether they work around it by
and they can be afford to be fined. The fine is worth it.
One of the ways that they work around it is to simply violate the law and pay whatever fine is imposed, and they just call that the cost of doing business.
That's right.
And then roll it into the next premium increase.
Right.
So we end up paying anyway. So really the main reason I am glad that PSARA and PNHP and so many other organizations are shining a bright light on the harms of and the profiteering of Medicare Advantage plans is not because I think we can come up with legislation that makes bad actors into good actors. I think really my goal in passing any of these piecemeal legislations is just to make it less and less profitable for them, so they find their stockholders, their shareholders say, okay, let's go take our marbles and invest them somewhere else, not in the healthcare industry, because it isn't the cash cow it used to be. And if that happened, hey, don't let the door hit you on the way out. Take your marbles and go invest them somewhere else.
Jaisri, I'm going to turn it back to you at this point.
All right. Yeah. Thanks for that great discussion. Really, tons of great food for thought there. I am going to ask Karen to close us out. And I do want to acknowledge that there were some other really great questions that we didn't get to, but it's probably time to close out here. So Karen, take it away.
Jaisri, I really think we didn't have enough time to really talk about this more. I think this is a topic that deserves a whole lot more discussion. So thank you, Dr. Paris and Dr. Singh, for being here tonight, and thank all of you who attended. I don't know if you can do this, but how about a big round of applause for our speakers? Thank you. Thank you for being here. I would encourage you to look and read the harms report that has been referenced here. It's quite the report. I also would ask you to look at our PSARA website. You can do that by, there it is, the scan. You can use the scan code or go to PSARA.org. We have a lot of resources that you might find helpful on this topic and others related to Medicare. We have our latest publication on our website. It's called Give Us a Real Choice, Level the Playing Field Between Traditional Medicare and Medicare Advantage. You'll find lots of articles that have been in our retiree advocate, including one by Jaisri on the topics of the harms that are happening with Medicare Advantage. So if you'd like to join us, please do. We'd love your support. Our webinar should be posted on our website in just a few days, and I would encourage you to share this widely. If you can, just go to the website and you'll find it there. So thank you all so very much for being here tonight, and we appreciate your participation, and check us out, talk about it, share it with everybody. Thank you.
Thank you all for having us.
Yes. Thanks indeed. Good night.
Bye. Thank you.